Good afternoon, and thank you again for joining us today. It's been a great event so far, and I'm very excited to introduce our next presentation and discussion, Leveraging Technology to Improve Data Aggregation, Interoperability, and Quality Measures in Value-Based Contracts. This session will present an overview of a population health partnership between HealthEC and Women and Children's Health Alliance, presented by Jake Peltzman, Executive Director of Women and Children's, and Sita Kappor, CIO and co-founder of HealthEC. Jake is an experienced physician practice and hospital administrator with a demonstrated history of working in the hospital and healthcare industry. He is entrepreneurial and professionally skilled in healthcare consulting, revenue cycle management, customer service, strategic planning, and business process improvement. Mr. Peltzman is passionate about improving health outcomes in the pediatric population and helping sustain independent practice through the Women and Children's Health Alliance. He holds an MBA from Rutgers and an MPH in healthcare policy from the University of Medicine and Dentistry of New Jersey. Sita Kappor is a healthcare IT entrepreneur and innovative leader directing HealthEC's research and development team, applying mathematical and computing models in customer development of large-scale data integration and analytics solutions that empower physicians and healthcare organizations to identify and engage at-risk patients requiring closer medical attention. Sita holds an MCS from the Stevens Institute of Technology in New Jersey. I'm also excited to report this year that HealthEC earned a 5-star rating by the Medicaid Black Book. The COVID epidemic has shown it to be disproportionately impacting at-risk communities and is now a critical time to improve the best care we can to all patients, but especially for those covered by Medicaid. So kudos to HealthEC on that news, and I hope we hear more about this in the excellent work today. Jake, Sita, thank you both for presenting today at the PHA Forum, and also from our audience, thank you for joining us. We have about 15 minutes at the Q&A, so please submit your questions in the forum platform. And with that, I'll hand things over to Sita, who will kick off the presentation.
Thank you, Dr. Sidorov. And thank you, everybody, for attending this. Jake and I are here today to share with you our journey and the platform and the usability of it in the industry. We will talk through the history and the business use case, the solution that we have provided, some actionable outcomes that the WICA has achieved, the quality measures, and at the very end, the Q&A, which is very important. With this, I will let Jake take it over.
Thank you, Sita. Thank you, Dr. Sidorov, both of you for the introduction. And I'm happy to be here today to talk about the Women and Children's Health Alliance and the wonderful things that we're doing to help advance pediatric care in the region. First, we'll give a little bit of background on our vision and how the Women and Children's Health Alliance became created. About 3 years ago, in 2017, there was, in the greater Abington, Pennsylvania area, a cadre of pediatricians, mostly independent in the region, that were constantly being pressured by health systems on their business model, in addition to health insurance companies challenging the revenue cycle and the reimbursement. And so we wanted to create a union of independent pediatricians that have been used to competing with each other for business and make them collaborate together to improve the care for children and improve their sustainability in the long run for independent pediatric practice. With that, we had a vision in mind, and the specific vision was to keep practices independent and fill care gaps to improve care, align strategically with our health system partners in the region, which is mainly on the adult side, Abington, Jefferson Health. On the pediatric side, there are a few pediatric hospitals that we wanted to be able to work with. And so we've reached out to them to be a part of our group as well. And we wanted to create specialty access in a region that historically has not had the greatest specialty access. Some challenges that we faced in doing that, obviously, was the rising cost of healthcare. What we found was that there was a real opportunity for independent practice to have a discussion, a meaningful discussion with payers, because of the substantial cost of children's hospitals being about 4 to 5 times more expensive than our independent practices. So we believed that health insurance companies would be interested in speaking with us to enter into value-based agreements to keep our practices sustainable, since we were so much less expensive than our hospital partners. The other push was the Affordable Care Act and payment reform and the transition from fee-for-service to value-based care. That it was a hot topic in 2017. It continues to be a hot topic. It's something that makes sense for everybody, and we wanted to be on the forefront of that. We also recognized that there were obstacles in care coordination within the healthcare system, and specifically within pediatrics, that we had a unique seat at. And so we wanted to work together to identify those opportunities, close those gaps, and improve care. And then there was a challenge with data aggregation. And so when we looked at our CIN, we recognized that there were about 12 unique electronic medical records in each of the in aggregate for the practices. And so we wanted to make sure that creating a network and joining a network was as easy as possible. And in order to do that, we couldn't ask folks to change their EMR, since you all know that's a major obstacle. And we needed to find a solution that would allow us to clinically integrate electronically without asking our practices to change their EMRs. You can want to advance the slide. The biggest driver was the shifting revenue cycle. As you know, the present state is fee-for-service encounters. It's basically encounter and volume driven based on a fee schedule, and key metrics were accounts receivable indicators. The future state of pediatric revenue cycle is going to be based on clinical performance, contracts with insurance companies that reward performance, bundled payments, especially for specialists. There's going to be a new business metrics that are out there, some that haven't even been defined yet. And it'll be largely consumer-driven healthcare. And the big push for that at the time was MACRA and MIPS. Although pediatrics is largely excluded from that in a lot of ways, the payers were very sensitive to it. And we knew it was an opportunity that we could start to demonstrate real value in the pediatric marketplace. And we really felt that creating a women and children's clinically integrated network would help address the quadruple aim of healthcare. So we wanted to make sure that we improve care. We wanted to make sure that we drove utilization to the proper site of service. We felt, by the nature of being independent and the nature of controlling a patient in general pediatrics, that we can keep costs low or even lower them further than they already are. And we wanted to be able to align not just the general pediatricians, but the subspecialists, the surgery centers in the region, and even the children's networks that are in our backyard to work together to improve care for the children in the region. And we wanted to direct consults to the appropriate network affiliated centers and specialists to, again, make sure that we're closing care gaps and we're reducing the cost of care.
Thank you, Jake. And with this, I'd like to share with you the solution that we put in place from HealthEC to help the Women and Children of Health Alliance come together. Again, they are in Pennsylvania, and they were independent pediatrics. There were 23 physician groups with 42 locations, including numerous children's health systems with over 130,000 plus covered lives. There were 125 providers with 100 general pediatricians associated with the Pennsylvania Medical Society. What HealthEC has been providing is a population health management data platform since 2018. So we took the challenges they had and we brought together our solution to help them with the opportunity that they were looking for, to coordinate the care management, to expand the covered lives, which currently they have a new contract with another payer, to minimize the leakage, to try and make sure that the patients that they were seeing and taking care of stayed within the network that they had set up for the clinically integrated network. Population health capabilities. Most importantly, we were leveraging an infrastructure that would allow us to collaborate the data and the care and the quality for reporting as well as documenting, which then leads to the most important thing, to expand the patient access, allowing multiple physicians to be able to see within a centralized all the data sets that they need to find. One of the very important things that we wanted to also bring in is that we have some proven results through the population health tools that we have deployed in the industry. We have been able to find a 29% reduction in ER, 20% reduction in hospital admits. How did you do these? These are all done by creating interventions and workflows which are actionable and allow very quick lists are provided that can then allow them to close these gaps and to reach the patients in a timely manner, allowing for that reduction. Increasing in the PCP visits, of course, if your patients are not doing as well, you bring them back to the office. This also then helps them ending up in an emergency room. Overall, by doing some of these clinical pathways, you're able to have a reduction in the PM/PM. There are a couple of examples that we have over here with multiple clients in the Pennsylvania, New Jersey, New York area. So the value proposition that we had for the pediatricians is building an attractive place, which is clinical, which will allow them to meet their clinically integrated goals. So you've got the incorporate the tools, the data, and the resources to enhance the current patient care delivery model and improve outcomes. Economically, the proven opportunities to reduce the cost of care and increase quality through clinical performance and patient access. Value-added services. So you created the infrastructure that benefits to ease challenges facing physicians, focusing on the greatest need of the population. At the very core, what HealthEC is bringing is aggregating the data from the multiple EMRs and the health plans to bring it into one universal data warehouse and to render the patient access to all the care providers and care nurses across the continuum of care. So instead of them being in the EMRs and trying to figure out or just taking care of the episodic care, you are now coming into a CIN where you have aggregated the data and created some actionable interventions, providing analytics for them to be able to very quickly find the population that needs the maximum care in this scenario. Coming to the actionable outcomes, Jake.
Thank you, Sita. So why a CIN for pediatricians? What's the purpose of having a pediatric only CIN? In our marketplace, I think the creation of CINs is largely based on the local networks. And in our local network, in the greater Abington, Pennsylvania area, a lot of the pediatric practices are owned by independent pediatricians. Many are advanced in their career and they've been around the block. And they were smart enough to recognize that the transition to value-based care is something that's going to be here to stay. And they wanted to be on the cutting edge of that. They want to practice high quality medicine. They are sensitive to the changing medical environment. And most specifically, they want to make sure they're doing the right thing by their patients. They want to make sure they're providing good care. They want to make sure that there's coordinated care for their patients and for the patients of their when they need specialists. They want to make sure that they maintain financial independence and they position themselves for long-term success. And as I mentioned earlier, the most important obstacle that we faced in creating a CIN was how do we not disrupt their existing EMR structure. Having practices change their EMRs was going to be a non-starter. We recognized that at the very outset of this. And we needed a platform like HealthEC to make sure that we could pull that off. And it had to be something that was reliable, It had to be something that was accurate, had to be something that was easy to access and easy to understand, because we recognized that we didn't have the bandwidth internally within the CIN, that we had to use the practices to be able to do that. And so we had to be software that was intuitive so that the practices were able to work the software for themselves. You can advance the slide, please. So prior to our CIN, there were very few options on the table for pediatricians. How are pediatricians that were independent going to remain in practice? They knew that there was a changing marketplace and they couldn't keep doing business as usual. And the number one, when we asked our network what the options were, their number one response was, we're going to keep doing what we've been doing and we're going to hope for the best. That was not an acceptable response for us. And so the CIN is something that could help maintain their independence and give them a solution for long-term viability. Another option for them was to become acquired. They could be acquired by health systems, or they could be acquired by a super group. And what we recognized in our community was that the advantage to our community was that we had a lot of independent entrepreneurial physicians. The disadvantage for our group was that we had a lot of independent entrepreneurial physicians, and they wanted to be in charge. The reason that they went out on their own to begin with was because they felt that they could do it better, and they were right. And so joining a group or being acquired was something that really was not something that they wanted to consider. And the ones that did consider it oftentimes were unhappy, or they were doing it because there was no succession plan in place. Another option was that they could join an adult CIN. You can go back real quick. They could join an adult CIN or a hospital-owned CIN. And the problem with a pediatric practice going to an adult CIN is that, for lack of a better term, they get stuck at the kids' table. And because the metrics in pediatrics are so small in terms of dollars for large adult networks, pediatric practices largely get overlooked or they get pushed around. And so creating a pediatric CIN was something that would make them, give them a seat at the table and control their own destiny. It also allowed them to create clinical integration and integrated business processes to help make sure that they were viable in the long run. So to that end, we have at this point about 23 practices that have joined the CIN with 42 different locations. An overwhelming majority are general pediatricians. We do have some specialists, as you can see, there's a few of them on this list. Our general pediatricians help us with our general Hedis metrics on cost of care, pharyngitis, antibiotics. Our specialists have joined because they want to support the movement, and they are low cost, high quality options for our total cost of care metrics. And so we like having both general pediatricians and independent specialists in our network. You will notice on this list that Nemours, which is Nemours Alfred I. DuPont Hospital for Children, is also partnered with us. And so they've been a large supporter of our network. And they've been a great addition to our family because we can draw on their research and their guidelines to help roll out high quality protocols for our practices. And we've been integrated with HealthEC for almost 2 years now. And now we have our first contract, which is coming due at the end of this year, at the end of 2020. And with HealthEC's help, we've been able to really identify gaps in care for our metrics. And so if you look at our dashboards, most of our metrics at the moment are Hedis metrics. Interestingly enough, we went to the payers and pitched the idea of metrics that were not Hedis metrics. But the payers were very interested in keeping it as Hedis metrics, in which we were happy to oblige. So most of the ones that you're going to see here are Hedis metrics. And when we started with HealthEC, our metrics were low. And you'll see here on the dashboard, HealthEC can customize their dashboard by payer per contract or overall with handy dandy red flags and specific metrics specific for our metrics. And it can give us our grades based on the integration of all of our practices. It can give us the scores that we score on each metric and our progress to plan. In addition, you'll notice that there's the plus signs on all the metrics, and those plus signs are expandable. Within that range, we can see the patients that were measured for that metric, the ones that met the goal, the ones that didn't meet the goal, and then the total denominator. So what this has helped us do is data mine in a one-shop platform. So the CIN leadership can look and say what practices, what providers are making the grade or not making the grade. In addition, we can say by patient. So when we approach a provider and we say, we tell them that they missed the metric, we can show them all the patients that are behind those metrics. Oftentimes, the payer's data is incorrect. And so HealthEC has helped us identify where the payer's data, where the gap in data accuracy from where the payers are to where the individual EMRs are. And we can pull that data out of the EMR to then go and have a meaningful discussion with the payers to discuss the scores that we're scoring on our dashboards. And it's very, very easy. And like I said earlier, we needed a platform because we don't have millions of dollars and we don't have a huge staff of 100 people that are doing data analytics in a corporate office. We're a staff of one, me, and we work all the practices, we mine their data, but we help the practices identify it, and then the practices will go through. And so we needed a tool that was very intuitive and easy to use for anybody within the practice. And HealthEC checked those boxes and has done a great job for us. Further, within the HealthEC platform, you get very easy to read graphs. And although most of you probably know this stuff, when you go to a payer and you have graphs that show the data that you're looking at, it helps them understand that you're a high quality group that has their act together and is interested in doing something very meaningful. When you go to the payers and you don't have this information, they don't just take your word for it that you know what you're doing. They laugh you out of the room. At least in our marketplace, they do. So it's helpful for us to have data at our fingertips in a meeting. We've been in meetings with payers where they ask a question and we can open up our laptops and log in and give them specific answers to their questions on the spot. And that's been valuable for us while we've gone through our negotiations with payers to help them understand that we know what we're doing and we should be taken seriously. And so we've had great outcomes with our discussions with payers, and we've had a fabulous experience with HealthEC. It's really helped us get organized and given us the sophistication that we need to be able to take our CIN to the next level. With that, we all look forward to the discussion, and I'd like to transition over to Dr. Sidorov to conclude the presentation. But we are very happy to get any questions or answer any questions or have any discussion and answer any question that you may have.
Thanks, Jake and Sita. What a great presentation. As a physician, I'm a general internist. I really enjoyed the description of a marvelous combination of both technology and provider care where it counts the most, you know, at the patient-facing level. For the audience out there, I remind everybody that there is space to type in your questions. Those questions will be aggregated and appear on screen, and I'll do my best to get to everyone's questions. To kick things off, I do have one question in particular, and this may be better aimed at Jake for starters. And that is, we just heard right before you a marvelous presentation from the employer community about what it is that they're doing to promote high value care among their employed populations. And I was wondering, Jake, if you could talk out loud or think out loud about all those moms out there in the workforce, especially at home now, with children who could use the services of a network, and the value proposition of your network, especially the information technology that you have and your ability to provide local care in the community away from big, expensive healthcare settings, how that would fit with an employer-based value proposition.
Yeah, it's a great question, and one that we get asked often. Specifically, our value proposition is not much different to our employers than it is to our large health insurance companies. So the MCOs and the payers and the employers have largely the same goals: provide high quality, high level of customer service with low cost. So our value proposition all along has been, we're in a very small community that has very expensive pediatric healthcare. And our independent primary care practices, and even our specialists, in order of magnitude, can be anywhere between 7 to 10 times less expensive than our health system colleagues. And so we believe that keeping practice local, keeping pediatric care local, delivering a high level of customer service with high level of quality is the right mix to make patients and families successful and to lower healthcare premiums for large employers. So as our network grows and we're able to offer more services, not just on the primary care side, but on the specialty care side, we hope to begin meaningful conversations with some large employers that are in our backyard.
That'll be great. We have questions coming in. This is for both of you. What was the reasoning of the rationale for developing and using non-Hedis measures with payers? How did that go? And why didn't they want the measures that you were proposing?
So I guess maybe I'll start, Sita, is that okay?
Yes, absolutely.
So it's interesting. When we started this journey, we had this grandiose idea that we were going to start to tell the payers what they wanted. And so when we first started conversations with them, we said these Hedis metrics, they don't make sense for pediatrics. And you should try to think about these other metrics. And as you can imagine, although the conversation was cordial, it didn't go real well with us telling them what we thought they should measure. And so to start all the conversations with the payers, they always started with the Hedis metrics. And what we've found is that, and this is probably judgmental, but that's well within their wheelhouse to discuss. And so they understand it. They have systems able to track it. It's something universal that they can compare and benchmark to other groups. And so they generally like to stay within their Hedis framework for their value-based discussions. And that's not to say that we haven't been successful highlighting the flaws in that. But to date, most of our conversations have always circled around the Hedis metrics. What I will say though, however, I'm sorry, Sita, I may want to jump in, is that one of the things that drew us to HealthEC was that they could build any metric that we needed to put into the system. So if one payer wants Hedis and another payer is willing to discuss a personalized metric, HealthEC is a great solution for us because they're able to accommodate that carve out for us.
Thanks, Jake. And that is so true. So one of the things we find is once the measures go to the providers and the doctors who are actually giving clinical care, they come back and they say, this doesn't make sense. And from their perspective, they have been managing these patients, especially in the pediatric care. And they're like, no, this age grouping is not correct, or this immunization should be split into 2 measures instead of a 1 measure. It's just not, it doesn't go with the workflow of what we are doing and what is the right clinical pathways that are needed. And that is where the challenge comes between what guidelines are there and what is the experience once you start getting to the pediatric practices. And that is the challenge we saw. And just to Jake's point, our system is configurable. So we were able to take a single measure and split it into 2 based on age group, or split it into 2 based on age and time frame. Is this immunization needed within 6 months or 9 months or 3 months? Those type of variances we were able to build very easily. And it is going to be a cyclic process as more of these value-based contracts come down to the clinicians who are going to start using it and comparing it to the guidelines they have and pushing back. So one of the doctors from Jake's organization was very aggressive. I think she said, I'm going to write to them and tell them this is what they're going to change. And as a matter of fact, they did. Some of those changes we're starting to see now in 2020 after she really went up and said, this is not possible. So it is great to see the collaboration that we're seeing out there. Thank you.
I've, as an aside, one of the things about this work, I've noticed in other settings, I've read in other settings, is that you begin to have adult conversations with the managed care organizations, and you win some, you lose some, but that's the way it goes in the world of population health and accountability. Sita, this is a question for you about the workflows and the information flows. How do you get the information to the pediatrician's office? Do they have to use HealthEC, or does the CIN use HealthEC and send the opportunities to pediatrics? Do they log on? Do all the docs log on to HealthEC, or is there an intermediary that's helping the docs with getting the right information in front of them? How does that work?
Absolutely, that's a great question, and that is something as an industry, as we start to move towards value-based care and there's a collaboration between the physician offices and the managed care organizations and workflows. And, we've heard a lot about, over administrative work for the physicians. They are burnt out. How do we help the physicians do what they do best while they still continue to support the concept of value-based care and quality measures? So for us to get data from the EMR systems, to aggregate it with the claims data, and to run the rules measures to determine what measures are, met or not met, compliant, non-compliant, open, not, whichever way you want to say it, the main focus really is to get to the physician when they see that patient, what they need to do. Or call the patient to take care of these 2 things because it's within that time frame that they need to be able to close a quality measure gap. For example, your immunization has to be done in that time frame, or your HbA1c lab test needs to be done in that time frame, or you need to get your flu shot. Right now, I hope everybody has got their flu shot because that's what you need to do in flu season. So how do we get those key interventions, open care gaps to the right people at the right time is always, it has been a challenge. And as we progress, we're starting to close some of those gaps. Everybody absolutely can log on to the HealthEC care coordination platform, and they can immediately be notified of what needs to be done today, tomorrow, or in the future. Furthermore, we also see that these can be moved, as what we would call in a workflow format back to the EMRs, so that when they open up the chart, they can open up this care gap. And at the same time, when they're taking care of the patient, they are going to be able to say, okay, generally it's not the physician, it could be the nurse or an assistant that is trying to make sure that these actions are taken, whether it's a reference or it's a a note that has to be given to the physician. So there are a lot of interoperable workflows, especially with FHIR v4 coming in, and the whole act towards interoperability and the openness that we are starting to see come legislatively towards us. I do feel in the coming years, we will be able to integrate more of these care workflows within the EMRs so that the people in the office, like I said, whether it's the doc or the nurse or the front office person, is able to manage everything from a single place.
Jake, this is a good question for you because I've heard you talk about this in other settings, and one person asks, how does the CIN handle pediatric member objections to standard approaches used by Hedis? And what I'm thinking of is that classic situation where if you're 1 day late with an immunization, you don't get credit, using Hedis, but the patient is still getting excellent clinical care, and you may have to push moms or parents or other child caretakers into coming in, sooner than they would otherwise find convenient. How do you navigate all that?
So the inner complexity of working with independent business owners is challenging, and working with passionate care providers and physicians and nurse practitioners and what have you is also very challenging. So we've got partners and a committee that handle most of those things. But to specifics, our CIN would not be able to be what it is without the support, the Care Centered Collaborative and the Pennsylvania Medical Society. They offer for us not only clinical support and negotiating support, but they also offer services for us to close our care gaps. And so if you're looking at care gap services, we have through them a team of folks that can call our patients ahead of time in advance of hitting those deadlines. Our providers are obviously very much on top of it, and they use the HealthEC platform to identify those patients. And then we have through the collaborative some real muscle with the payers to get in the door and negotiate and discuss options on how to work with some of those exceptions. And at the end of the day, our workflow is our escalation factors. It starts with the physician, and then it typically will come to me, and then we'll roll that in front of a committee. The committee will work with the provider and the provider's office to help resolve any disputes. And if it's payer related, then we work with the collaborative and HealthEC to address it with the payer. And so having an entity, both entities, like the collaborative and HealthEC, having their connections and influence and power has helped us get to where we are and helped us resolve many of those disputes when they come up. Does that answer the question?
Yes. Well, I'll leave it to the questioner because he or she may want to put in another follow-up question, which would certainly welcome. Lots of questions coming in, no shortage here. This is both for Sita and Jake. If you were king of the world and you could develop a single non-Hedis measure, or we'll give you one or two non-Hedis measures that you think would be most valuable in the pediatric population to promote value, what would it be?
Oh boy, that's a really good question. I don't know if I could think of a specific measure. Maybe something related to, you know what? I think for us, something related to behavioral health would be probably the largest, something with the largest impact. So what we're seeing on the ground are more and more patients with developmental or behavioral health issues. They take up a lot of time for our providers, and our providers generally are slightly nervous about taking care of some of those patients. And I think that if we could come up with a way where we got paid for the value of managing those behavioral health patients, making sure that they're healthy, and not utilizing too many specialists. I think that would go a long way for the payers in controlling cost. I think it would go a long way for the patients in terms of getting the care that they want and need when and where they want and need it. And I think it would go a long way for the providers in helping them deliver meaningful care to their patients so that they don't feel that they're spending too little time and that they're really delivering the value that they want to deliver.
Sita, I was going to say, see, you bring a national perspective here. What are you seeing out in other areas of the country?
Yeah, what I'm seeing out there is most of our measures are for, I don't want to use the wrong political word, but for regular people. What we don't find measures is for kids, who have ADHD or autism or other specialties. And that's across the board that we're starting to see. So how do we have a measure or something that's going to help us determine that the best care is being given to that population that we have? So they could be behavioral health, they could be, other challenges that these children are having. So I would recommend at least some measures in there to help guide and manage the population that we're not doing anything for.
We have about 3 minutes to go, so this is going to be the last question, and it has to do with the interface using the electronic health record, and then there's the interface with another technology, HealthEC, and for example, HealthEC. The question posed is, how do you get the two more proximate to each other? And specifically, can you receive referrals and do orders within the system across different electronic health records using HealthEC?
Jacob, you want me to take that?
Well, I'll answer it to the best that I can. Sita is an expert at HealthEC. I would say I'm beginner to intermediate. But it's a good question. The interfacing between the EMRs and HealthEC, so in my opinion, HealthEC makes it very easy to interface. But on the other side, some of the EMRs make it very difficult. Some also make it easier. Some are not so bad. But generally speaking, at least from my perspective, the integration on the HealthEC side was pretty easy, but working with the individual EMRs to build that integration was very challenging. To answer the question about the referrals and whatnot, through the CCDA files, I'm not sure if you could issue referrals, but what has helped us on the CCDA files is that we can see what's happened in each of the practices. So if a patient goes to practice A and they're on Epic, per se, for example, and then they go to patient B and that patient has Office Practicum, for example, we can see what happened in each other's offices. And so the CCDA files have been very helpful in coordinating care. I'm not sure Sita can answer the referral question much better than I can, but at least in being able to see and keep the loop closed and updated, the CCDA component of HealthEC has been very useful for us.
Sita, you have about 30 seconds.
Referral is the most broken process in our industry. I have a blog with four parts in it. Everything said and done, we can do a lot, but the place that we lack the most is referrals, pre-auths, and appointment scheduling. In an enterprise level, if I had a wish, that is one of the things I would like to fix before I end my career. So I would take that as a challenge and bring it to the industry as a challenge to see how we can integrate all of this.
Well said. Jake, Sita, thank you so much for your time and an excellent presentation. Let's move on to the next part of the agenda, applying leading edge technology to connect community and care. I'm really looking forward to it. Once again, Sita, Jake, thank you so much.
Thank you, everybody.